Thank you for tuning in to our best practice series for medical providers working with refugee and immigrant youth and families. This is one video in a larger series hosted by the Trauma and Community Resilience Center at Boston Children's Hospital. Each short video will highlight experts in the fields of medicine and psychology who work with refugee and immigrant youth and families. We are grateful to SAMHSA and the National Child Traumatic Stress Network for their support in making this series possible. In this video, we will be hearing from Drs. Shannon O'Malley and Francis Cheng. Shannon O'Malley, MD, is an assistant professor of clinical pediatrics in the section of hospital medicine, deputy director of the YNHCH's clinical pathway program, and an inpatient medical director at YNHCH, or Yale New Haven Children's Hospital. Her non-clinical interests are advocacy and public policy, health education, and community-based participatory research, particularly within the local refugee and immigrant community. She serves on the executive board of Academic Pediatric Association's Public Policy and Advocacy Committee and is a faculty advisor of the Yale Health Education and Literacy for Asylees and Refugees, or Y-HEALAR program, and was a co-founder of the Yale Peds Residency longitudinal advocacy curriculum. Francis Cheng, MD, is also an assistant professor of clinical pediatrics in the section of hospital medicine at Yale School of Medicine. She co-founded and now serves as a faculty co-advisor for the Y-HEALAR program, an academic community partnership providing health education classes for the refugee community in New Haven, and is a co-chair for the AAP Section on Hospital Medicine's Subcommittee on Global Health. Her academic interests are in global health, refugee and immigrant health, and neonatal opioid withdrawal syndrome. Francis and Shannon are currently working together with several refugee-serving community organizations on a PCORI-funded project aimed at strengthening research capacity within the refugee community in New Haven, Connecticut. And I'll pass it to Shannon and Francis now.
Thank you, Dr. Butala. Dr. Cheng and I are honored to be part of this best practice series for medical providers who work with refugee and immigrant youth. This webinar will focus on the inpatient care of children who are refugees and immigrants. So our objectives for today for this webinar are threefold. One, identify two key considerations unique to the care of patients who are refugee and immigrants. Two, discuss components of focused migration history and name one strategy in counseling a patient with limited health literacy. And three, develop two actionable strategies for implementing practice change related to the care of these children. To reach these objectives, we will use a clinical inpatient medical case to weave each of the following important sections into our discussion. Our outline includes a general background, discusses how to obtain a brief migration history, understanding some unique health disparities these populations face, a brief overview of trauma-informed care, and how to recognize and address disparities related to populations who speak languages other than English and may have limited health literacy, transitioning care to the medical home, and finally, how to optimize the hospital environment for these youth and their families.
Thank you. So for some background, the number of child refugees is growing significantly. The number between 2005 and 2021, the global number of child refugees under the UN High Commission for Refugees Protection more than doubled from 4 million to over 10 million. And children are also overrepresented among refugees. Although they make up a third of the world's population, they now account for over 40% of all refugees. Next slide. So Bronfman-Benner's ecological systems theory is a helpful framework for understanding the many overlapping systems that can affect a child's development, their family, their community, and the policies that shape their lives. Starting with the child in the center, we next go to the microsystem, which is comprised of their daily environment, including parents, caregivers, and immediate family. For the mesosystem, this involves interactions between those in the microsystem. For example, family and school communication, and other communication with supportive and supported professionals. The exosystem includes indirect influences, which include local services, parents' workplaces, friends, and the community economy. The macrosystem involves broader cultural influences, including ideologies, socioeconomic status, laws, poverty, and ethnicity. And the chronosystem includes life transitions and events such as parental trauma or migration experiences. So for children who are refugee and immigrants, many of these systems have been disrupted or even traumatizing, which is why it's important to think ecologically about them and why it's so important for clinical care. Now we'll talk about some of the different terms. A refugee has legal status. They've fled due to war or persecution and can't safely return home. Whereas asylum seekers are in a similar situation, but they're still in the process of seeking legal protection. Migrants may have left for economic or other reasons, and unaccompanied minors are, as it sounds, children who arrive without a parent or guardian. Unless we're specifically talking about one group, we will, for the rest of this talk, use a similar framework to the AAP, and we'll use immigrant children to include all of these groups. Next slide. So these are some of the health risks for children in immigrant families. They don't just start when families arrive, and they can happen across the spectrum of the migration journey. Before migration, children can face things like limited access to healthcare, poor nutrition, or exposure to trauma. During the journey, there can be dangers like detention, hunger, separation from family, and even violence. And after arrival, a lot of the families can be dealing with poverty, discrimination, and loss of their community or sense of identity. So all of these experiences will build on each other, and they can affect how children show up in our hospital, how families interact with the healthcare system. And because of that, they should also inform how we can make decisions in clinical care. So because of their journey, these are some of the barriers that they may face once they arrive in the US. So they can face a difference in language, as well as differences in parental literacy, culturally concordant providers, and culturally sensitive screening, and also immigration-related fears. So trusting the providers and other stressors, answering questions, and sharing their stories can be difficult. So we need to recognize that just by walking through our doors of the hospital, it's a big deal for some of these families. Now we'll start with our case. So you are caring for a 4-year-old girl who is Arabic speaking. She presents with 1 week of progressive right-sided neck swelling, fever, and nausea. She is febrile, but otherwise has normal vitals and has 1.5 centimeter right-sided non-tender lymphadenopathy. She's appropriately started on IV antibiotics. So our first question is, how would you approach identifying this child as an immigrant if it's not in the chart? How would you ask? And once you learn that they are an immigrant, what questions would you ask to gather a migration history? So for every new patient, especially if it's their first presentation to care, you can ask, where was your child born? And then for all patients who are immigrants, you can also ask, have you moved from another country recently? This can open the door to understand some of the risks, possible gaps in care, and family context. Once you've learned that they are an immigrant, you can ask, if you feel comfortable sharing, can you tell me about your journey? You'll want to get a sense of the pre-migration history. That includes where they were born, their language and dialect. And then during migration, what countries they passed through and what those experiences were like, how long they spent living in those countries. And after they've migrated to the US, how long they've been here, whether they were detained, and what their current housing and living situation is like. It sounds like a lot, but even these short conversations can be very helpful.
From your history, you learn your patient's family recently arrived from Syria and her mom is receiving treatment for active TB. How does this family status as immigrants impact the differential that you had for her lymphadenitis? And what other health concerns should you consider when caring for this child and her family in the hospital? So for the immigrant child, one of the most important categories to have on your list is infectious diseases because it's a top health concern for newly arrived immigrants and is often related to their presentation. Not only for this patient, but for all newly arrived immigrants, we recommend testing for TB, which has varying prevalence as noted in the map from the World Health Organization on the right. Additionally, immigrants may be under-vaccinated and thus at risk for vaccine-preventable illnesses like measles, hepatitis, varicella, or chickenpox. Aside from the infectious disease concerns we discussed, immigrant children also face a variety of unique health disparities, which we will talk about in the next few slides. Briefly, for example, they are more likely to be affected by both under or overnutrition and present with undiagnosed health conditions, things like elevated lead or sickle cell, thyroid disease, or G6PD. And this might be because they are less likely to have received newborn screening, which is typical here in the United States and would catch these disorders at an early age. Additionally, generally they have higher prevalence of mental health disorders due to the trauma they experienced before, during, and after migration. They're also less likely to have been screened prior to their arrival, and they are potentially less likely to openly discuss these issues based on cultural norms. We recognize that the approach to screening and vaccinations in the hospital may be more limited than in the outpatient setting. But if the hospitalization is the first presentation to care in the United States for this family, or if it could be related to the child's presenting symptom in the hospital, or if there's concern that there will be difficulty in transitioning to a medical home, we'd recommend thinking more in depth about the unique screening and vaccination needs of the immigrant hospital child. We also recognize that it may vary greatly depending on the child's age, their past medical history, their country of origin, or perhaps where they were prior to arriving to the US. So the first QR code in the upper right-hand corner links to a page from the Minnesota Department of Public Health, where you can enter all of the child's unique health history, as well as the state in which you practice, to help guide what you would do in the hospital. It also does ask about the child's health records, which may be incomplete. So potentially you may need to do more testing than you would have if you had the full list. Additionally, based on the recommendations of the AAP Immigrant Health Child Toolkit, which is linked with the QR code in the bottom right, you should potentially consider testing for the following infectious diseases like TB, Hep B, HIV, syphilis, and additionally lead because of the reasons we've already discussed, as well as considering starting immunizations in the hospital if these things have not already been done.
So now we're going to go back to our case. And at this point, you might be wondering, how do I engage with this family and child in a way that feels safe, supportive, and respectful? What does trauma-informed care look like in this context? And this is where a trauma-informed approach is important to help us meet families where they are and respond in ways that promote healing rather than unintentionally causing harm. Trauma-informed care has been shown to help kids and families feel safe, improve outcomes, and help providers by reducing burnout. So the Substance Abuse and Mental Health Services Administration, or SAMHSA, lays out 6 principles, which we'll go over: safety, trust, peer support, collaboration, empowerment, and cultural responsiveness. A lot of this may sound familiar, and that's because a lot of us are already practicing parts of trauma-informed care every day. And most of us do aim to be thoughtful, kind, and respectful with all of our patients. But what trauma-informed care does is give us a shared framework, and it helps us to be more intentional, especially when working with families who may have experienced profound trauma or whose trust in the systems has been broken. And this is just a brief overview, like we mentioned, and we would encourage you to seek out formal learning opportunities and in-depth resources, which we'll be sharing at the end of this talk to help get started. So the first principle is safety, which means physical safety, but also emotional safety. And we can build this with simple actions like introductions, explaining what we're doing, and creating an environment that is respectful and predictable. For trustworthiness and transparency, for families who may have experienced systemic distrust in healthcare systems or maybe in immigration systems, this can be a big part. We can build trust by being clear, consistent, and honest, listening to the patient's personal experiences. And it's okay to say, I don't know, but I'll find out. For peer support, this is about community. Immigrant families may rely on networks of shared experience. And in the hospital, this might look like connecting families to peer navigators, community health workers, or culturally relevant support groups if they're available. For collaboration and mutuality, this is about recognizing the expertise that families bring for their knowledge of their child, their culture, and their goals, and working together and encouraging shared decision-making when possible. For empowerment, voice, and choice, this means giving families choices whenever possible, even small decisions. For example, whether to have an interpreter in person or by phone can give a sense of agency, especially when so much has been out of their control. And then for the last point, cultural, historical, and gender issues, this asks us to reflect on how trauma intersects with culture, race, religion, gender identity, and historical context. And it's a reminder to remain curious and respectful. For example, asking how someone prefers to be addressed or what beliefs shape their healthcare decisions can go a long way in building trust. And so by using these principles, we can create an environment where families feel heard and respected and empowered and lead to better outcomes for both the children and the providers.
Okay, back to the case. So your patient is being taken to the OR for an IND due to concern for abscess and to obtain cultures. How do you prepare this child and family for the procedure? We would recommend a tailored communication approach and believe a quote from the 2018 article pictured here highlights an important point. Giving hospitalized immigrant and refugee children the chance to reclaim the telling of their story in a medium that is their own, such as through play, restores agency and control over their story to the child or adolescent. So most importantly, we would say that if your hospital has access to child life, we would recommend utilizing them for culturally sensitive, developmentally appropriate support and medical play to reduce anxiety. And when speaking with the family, it's also important to give them as much agency and control as possible in these situations. Thankfully, the procedure goes well. When pre-rounding the next day, you are surprised to see, however, that the child did not receive any pain medications, and minimal documentation is provided of the overnight events. When speaking with the mother, you learn that there was no interpreter use overnight, and she also reports that the child seemed very uncomfortable throughout the night. What risks do populations who speak languages other than English face in the hospital setting, and how can these challenges be addressed? Unfortunately, families who speak languages other than English are at risk for more preventable adverse events and adverse events overall while hospitalized. As in the case of this child, they are also more at risk to have higher pain scores than are documented and also be treated less for their pain than families who speak English. Additionally, we know that the time of discharge can be a particularly high-risk time for these families, leading to things like a non-comprehensive care plan at discharge, more emergency room visits after discharge, and medication errors. Though not a comprehensive list, we will discuss evidence-based approaches to communication for these families involving interpretation and translation. So for interpretation, we recommend the following: using interpreters whenever possible and using short, clear phrases and making sure to tell families that this is the expectation for the visit as well. When speaking, we would recommend speaking directly to the patient and family instead of the interpreter. And in general, children should never interpret for their families. For translation, we recommend considering health literacy, which we'll talk more about in the coming slides, and using things like visual aids, specifically things like calendars when there's medications involved. We can also discuss with the family that they can record the discharge education that you provide and save it on their phone when needed. We can also apply the following evidence-based practices from the field of limited health literacy using these three basic strategies. So one is chunking. So especially at discharge, breaking down information into smaller, more manageable pieces can be very helpful. 2 is something called teach back. And we recommend using the phrase, "Can you tell me in your own words what I just explained?" to give the family an opportunity to state back what they have understood. A third way is show back. And we recommend for that using the phrase, "Can you show me how you would give this medication at home?" And this is the family actually demonstrating how they would do something. So using these 3 together can be very helpful. Case continued. So the cultures do come back positive for MAC. ENT removed the drain, and you adjust treatment to appropriate antibiotics. Your patient is transitioned to oral medications with the plan for discharge home. What are the best practices for preparing this family for discharge? So as we discussed, discharge is a time of risk for these youth and families, and it's often very difficult due to time constraints, but spending extra time to ensure successful transition to a medical home is a key part of their care plan. In an article entitled "Immigrant Mothers and Their Perspectives on Pediatric Primary Care," which surveyed mothers from several different regions, the following challenges came up. So just overall, they identified significant barriers at every stage in the process from moving from the hospital to a medical home. And specifically, they found issues with making appointments, attending appointments, follow-up, and continuity with the same providers. And then additionally, they just wanted providers to know that the US approach to healthcare is often very, very different from where they have come from. So recognizing that, and again, giving families as much agency and education as you can in this process can be very helpful. In order to successfully transition to the medical home, we recommend the following things. Again, recognizing that the hospital setting can be difficult with time constraints, but knowing how high risk these families are. To ask initially at admission, if possible, if they have a medical home, as identifying a medical home can take some time, and finding one that's culturally sensitive and humble and can provide the full services. So if they do not, we would say from the beginning, think about the screenings and vaccinations, as we have mentioned, and potentially providing more of those in the hospital. Once you do have the medical home, more than ever, we would recommend providing that warm handoff to the provider or providers that will take care of them, utilizing your resources in the hospital to help actually schedule those appointments for the families, and additionally arrange transportation as able, so that you can ensure a safe discharge, ensuring access to the medications in hand. So if your hospital has a program where medications can be delivered to the bedside, we would recommend that for these families, so that you could do the teach back and the show back. When you do that warm handoff, discussing any unmet needs with the pediatrician, like referrals that need to be made, vaccinations that need to be given, or testing that was not done. And then most importantly, providing the discharge instructions in the family's preferred language.
Well, bringing our discussion back to the clinical setting, we'll revisit our case. The child is appropriately discharged home in good condition, which is wonderful. But this is also a valuable opportunity for us to reflect. What strategies can we as a team implement to enhance the healthcare experience and overall outcomes for other immigrant children that we care for? So one of these strategies is cultural humility. This is different than cultural competence, which focuses on learning specific knowledge about different cultures. But cultural humility is a dynamic process, being open, curious, and willing to learn, and honoring the family's expertise in their own lives. And we can break it down into these key components: educate, build, collaborate, support, and advocate. So education includes recognizing immigrant families and learning about the most populous groups that are in your area, and exploring cultural practices that are specific for these groups. And we have a link to a QR code here for newcomer profiles, which you can look at to look at cultural practices and profiles of the groups that are most populous in your area. Next is build and collaborate, which means creating a welcoming and supportive hospital environment. Practically, this can involve advocating for refugee family representation on patient and family advisory councils. Many of the hospital-based family advisory councils only have patients who speak English, so advocating for that representation can be helpful. Partnering with community organizations to better understand the challenges that these families face and being aware of the community's needs beyond the hospital walls. And it also includes focusing on language and cultural sensitivity. This includes some of the things Dr. O'Malley mentioned, like providing materials in the family's language and signs that are in the hospital room and discharge instructions in the family's preferred language. It also includes having represented photos of children and families on hospital materials, as well as offering culturally appropriate food, such as halal meals from the cafeteria, or being mindful of food timing during religious holidays, for example, before sunrise for Ramadan. Next is support and advocate. And to illustrate this, we'll look at a case study of a children's hospital that recently published an article in Pediatrics in February of 2025 about their inpatient asylum protocol, or IAP, that was implemented to support asylum-seeking children and families with social work, case management, and legal assistance. They used the screener question of, has the child recently moved, to identify immigrants and refugees. Over 2.5 years, 47 patients were enrolled. They identified significant needs in food, housing, and legal support. And half of their patients required subspecialty consultations, and 13% were enrolled in the complex care program. They found that a majority of their patients, 93% of families without legal aid, were able to be connected with resources, and 96% of patients without a primary care physician established one by discharge. So this is an example of how we can improve access to resources in healthcare by providing comprehensive support. Building off of that, we would recommend connection with social services at discharge and during the hospitalization. Connecting families to legal aid and housing assistance, as well as supporting school enrollment and providing educational resources, can be helpful. Also, providing transportation support and car seat resources and training, as well as assessing for psychosocial stressors, can be helpful.
To conclude our presentation, we wanted to just go over a few final summary points. So one is the importance of engaging with families with the willingness to learn about the unique perspectives, recognizing that each immigrant family has their own things that they've gone through, and recognizing that they are the experts in their care. Applying trauma-informed and culturally humble approaches to these families, utilizing interpreters to ensure clear communication with each encounter, and as best as you can, facilitating access to necessary providers, support services, and resources after hospitalization. Thank you so much for listening to our webinar today. Here's our contact information for Dr. Cheng and myself, and a QR code with a full resource list for the resources that we mentioned during this PowerPoint, as well as additional others that we've prepared. And thank you for allowing us to be part of the Best Practice webinar series.
Thank you so much to Dr. Cheng and Dr. O'Malley for sharing your expertise with us, and thank you to all of you for watching. If you're interested in learning more, visit our YouTube channel for more videos. The link is in this video description.